Thank you, Lord Rees. Very kind of you, very kind introduction. And may I firstly thank the Academy for your very kind invitation, joining this august group. As Lord Rees said earlier, I'm a surgeon, so the last thing I should know about is public health. But I've realized about a decade ago, and actually, in fact, when I was the minister, we had H1N1. And I remember the support that Lord Rees and Lord May gave me throughout that period of time. It's a very different story now. I'll start by saying, again, United Kingdom was the first country in the world to use a public health legislation back in 1847. And since then, if I could just make this remark, that in the 20th century, the first half of the 20th century, public health measures, and subsequently in the second half of the 20th century, through science and innovation, life expectancy was doubled. There hasn't been any other contributor to life expectancy in humanity rather than public health combined with science and innovation. Saying that though, public health has lost its way, certainly in our country, with lack of investment. More importantly, the lack of investment in academic training in public health, which has been a serious issue. And also, politics is about, Lord Rees very eloquently said it earlier, politics is about today and tomorrow. It is not about the future. Public health is about the future. And so I'm going to share with you a concept that I have been involved in pre-COVID, may I just say. For some reason, it's become very relevant now, post-COVID, which is sort of a contemporary public health, which I describe as health security. Some have described it as health protection, but I've added the word security just to be controversial. So I'm going to share with you the slides, and if I could get them up. Are you able to see this?
Yes.
Mm-hmm. Thank you. And this is a piece of work that I've done with Nubar Afayan across the pond from Harvard, looking at a vision in public health for the future and how do we secure that. I think as a society, we've struggled with our broken healthcare system. Although David very eloquently described the burden on the health and also the major contribution that most healthcare system has done in COVID. But most of our healthcare systems are sickness services. They're primarily focused on treating ill rather than maximizing well-being. And there are very few innovations in terms of protecting our health. As an individual, member of society, all of us in this room, we'd be more fatalistic in terms of health and well-being. We've been vigilant regarding our physical security. I don't think any of us will expect anything else other than the government providing us with the security we need. We have locks, we have seat belts, we have smoke alarms. But when it comes to our own health, we seem to abdicate that responsibility to others. And I think this status quo is inefficient, economically definitely unsustainable, and I will share with you why, and cost years of enjoyable and productive life. And I think COVID has really brought that up to its head. We need a paradigm shift, the way I see it, health being a national security matter. I think David very eloquently described his experience when it comes to it, but that's been mostly concentrated on a pandemic. I think we should stretch that thinking beyond a pandemic. It's not just about addressing the challenges or external threats, such as a new virus, but it's also addressing the increasing pre-disease burden states that we are seeing and challenged with in most healthcare systems. So essentially what I'm asking for is most of a rebalancing in our investment between preventative, prevention, threat identification and threat management, and also more reactive interventions in pre-disease state. If we look at our healthcare expenditure, wherever you come from, that expenditure increases 2% above GDP annually. US spends 17.1% of their GDP. The UK spends near enough 9.5%. Let me just say expenditure has no correlation whatsoever in terms of life expectancy or the quality of life adjusted measures that you get from any of these systems. This is what it was in 2013 to 17. This is what will be in 2022. And global health expenditure next year will reach a massive figure of about $10 trillion. That's a significant amount of money. And not necessarily, it may prolong life, but the quality of these live years is questionable. With that 10 trillion expenditure, I just wanted to highlight to you how much do we spend on public health. Less than 3% of health expenditure goes into prevention. It's about 2.8%, and you can see what they are. And out of that 2.8%, if you look at the figure on the right, significant, more than 40% of that, it goes really into healthy condition monitoring. Obviously, some goes into immunization, in other words, the 9% of the 2.8%, but that's a very minuscule amount of money if you really want to keep your nation secure and healthy. And that's not just physical, by the way, also mental health and social health. If you look at the return on investment, if you're an economist looking at impact and return, there is no question the best buys in any healthcare system, including ours, which has a universal health coverage, are preventative interventions. For every dollar spent on immunization, the return is $16 to $44. And this whole list is there to prove to us that this is a worthy investment. But as I remind you again what I said earlier, the return on this investment take years, unlike investing on expanding a bed base to reduce the waiting list. So the case I make in terms of health security is individuals need to take the health security issue as seriously as their physical security. Government needs to view the population as a health security. And I was delighted to hear, and I'm not sure, maybe David saw this or Lord Rees saw this, last week, our Prime Minister started to talk about health security and bringing it up to the G7 as a point of discussion. On the left-hand side, we continue, in my own profession in surgery, diagnose disease, treat disease, provide palliative care. We need to move into provide maximal health protection, detect and treat pre-disease states, prevent and delay disease, and then mitigate that. If we just look at the cost of COVID, and this is the costings done by the World Economic Output published in April of this year, we're talking about $1 trillion per month. And by the way, SARS-CoV-19 has probably the least case fatality ratio, as you see on the right-hand side, in contrast to its predecessors like SARS or MERS. And thank goodness they didn't disseminate the same way as SARS-CoV-19 did. So this investment becomes even more of an opportunity in the future if we are to deal with these new pandemic threats. May I also throw this at you? Pandemic has always been described as a viral pandemic or a flu pandemic, but the definition of pandemic isn't just about an infective agent. Pandemic is about a disease that goes across larger populations of people. And COVID may prove to be, as I said earlier, one of the least deadliest pandemics that will be facing the world over the next 10 or 20 years. Beside pathogens on the left-hand side, and let's not forget AMR, in the next 20 years, there is a potential of 69 million people losing their lives on the back of antimicrobial resistance. With prediction, so far 1 million, but by the end of the vaccination program globally, we anticipate greater than 3 million deaths from COVID-19. Diet and exercise in its contribution to ischemic heart disease, diabetes, that we have a pandemic of diabetes. We are about to get a pandemic of Alzheimer's and stroke. Technology in the last century added years to our life. We need to start thinking, how do we add life to these years? And then finally, on the right-hand side, some of the societal challenges that continue to haunt us, and they are reaching the phase of a pandemic as well. So health security is about having a system that constantly monitors. It's a surveillance system. If there is a threat, whether that threat is a profile threat, a genetic disease, diet, lifestyle, and we do have the science and technology to stratify and detect those, whether it's an assailant threat like COVID, any pathogen, toxins, allergens. Allergens, we're getting also a plethora, significant increase in prevalence of allergies, or even an event threat, injury, surgery, sleep deprivation. We have a pandemic of sleep deprivation impacting mental health and stress. So monitoring surveillance, which leads to pre-disease prediction and detection, moving into a platform of innovations that actually will deter and mitigate that. Could be protective foods, microbiome, tuning healthy behaviors, behavioral psychology, and then finally, prevention and neutralization, small molecules, biologics, vaccines. I'm sure there are a number of scientists on this group who will say that with artificial intelligence, we can actually predict at least 35 variations of coronavirus possible. Why don't we develop antibodies to these? But who's going to pay for these? Where do we keep them? Is some of the challenges facing us. In disease-focused areas, healthcare, we've done remarkable, absolutely remarkable work in terms of personalized medicine, genetic therapies, precision cancer treatment. In my own field, cancer treatment, I'm a cancer surgeon, completely transformed from the days of my earlier training days as a surgeon. However, we still have a broad brush general type of therapeutics, antidepressants, analgesics, anti-inflammatories. We know that inflammation is at least through 30 or 40 different phenotypic types of diseases rather than a single brush treating them with an anti-inflammatories. When it comes to pre-disease focus, with the exception of what we know in the classical public health, childhood vaccination, screening programs, which actually we've had them for nearly 30, 40 years, since 1960s, we haven't really moved on, with a few exceptions. Recently, an introduction of a new drug, which is the PCSK9 antagonist to a PCSK gene, which increases your cholesterol level, was transformational because now you can treat individuals on a more specific and a personalized way. We need more. The top right-hand box is still empty. We need to move, as we have, in disease focus from traditional sick care into new models of sick care medicine, personalized. We need to do exactly the same where today's public health is and shift that into the box of what I describe as our health security. And this is the moment to do this, as we did post the war, in terms of gathering big nations to think about this. And if you remember, I mean, people say we're investing a huge amount of funding on nuclear weapons. Nuclear weapons haven't been used, but they work every day. They work every day because they provide us with that security that we can address a challenge if that ever arises. Just give me two pathways of care. Patients with colitis, full health, we only pick up in a pre-disease state if they happen to come in for another complaint. Most are picked up in a mild or moderate disease, which get treated, for example, with ASAs, which are anti-inflammatories. Patient goes back, they get a further deterioration to severe disease, they come back to biologics. What if we have a pathway that we can pick pre-patient's disease state with certain biomarkers, intervene with tailored interventions to return them back to full life? Tailored interventions delay the disease. In another scenario, lead to slower and shallower decline. In other words, helping the citizen through that journey before they reach the severe or may even never reach the severe disease state. And if you do any economic calculation on this, it is cheaper. And if you look at pre-disease state, by the way, 30% of our adult population are prehypertensive. 350 million worldwide have prediabetes. 200 million in the US and the EU are pre-rheumatoid arthritis. 40% of women greater than 50 years have osteopenia. We do know this, we can measure it, we do have certain technologies to measure it, but we're not intervening until the late stage of disease. So health security, future of public health is about investing in new diagnostics, predict the likelihood of pre-disease, the severity and the comorbidity, prophylactic type of interventions, and we do have the technology platforms and newer therapeutics in terms of mitigating the comorbidity. To do that, we need a completely different mindset change in terms of commissioning and supporting. Ultimately, all of this will only happen by stimulating the scientific community in investing financially and academically in building platforms of technologies that are there to address the pre-disease state, but also to have and available to us if another pandemic hits our shores, whether that happens to be the discovery of the antibody or the synthesis of that, or manufacturing of vaccine lines, or whatever it happens to be. And saying that, though, we do have to acknowledge in the history of humanity, we've never had a vaccine developed in such a short period of time. And we all hope it will be a success. We also need to work with the regulators. We need very new valuation model rather than a quality depending on quality of adjusted life years and the new regulatory pathways. I think with these principles, we will be able to reinvigorate public health and really celebrate the amazing achievements of public health in the early part of the 20th century and take it to the stage where will dramatically improve, as I said, not just the increasing the number of years that we live, but the quality of the years that we have extended. On that note, again, thank you for having me. I'll be more than happy if Lord Rees agrees to take a few questions.
Yes.